All right, I'm Brad Stoner. I'm the Department Head for Public Health Sciences. I want to welcome everyone to our first Public Health Sciences seminar series of the year. We're delighted to welcome our illustrious speaker, and I'll get to that in just a second. But first of all, thank all of you for coming, and thank you for managing early in the semester with our ongoing issues related to keeping everyone safe. We are mask friendly, mask forward, so we will be we're recommending masks, at least for the time being, and delighted to have you here in person or on Zoom. It is our tradition to start these seminar series presentations with a land acknowledgement. So I want to begin by acknowledging that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory, and we are grateful to be able to live, learn, and play on these lands. For our first seminar series today, I'm delighted to welcome Dr. Maria Ospina. Dr. Ospina is a clinical epidemiologist and population health researcher, former Canada Research Chair in Life Course, Social Environments and Health, and currently an associate professor with the Department of Public Health Sciences here at Queen's. She maintains an adjunct faculty status at the University of Alberta School of Public Health, where she was previously very research active. And her program of research involves the routine use of perinatal and administrative health data and other clinical data sources to examine the impact of early life factors on long-term health and the role of social and environmental determinants on maternal, perinatal, and childhood health. Her work is supported by Canadian Institutes of Health Research, Lung Association, Respiratory Health Strategic Clinical Network, and a variety of other sources. She's currently Secretary of the Developmental Origins of Health and Disease Canada Society, or DOHA. I'm going to pass it over to Dr. Ospina. We'll let her make her presentation. We'll hopefully have time for questions at the end. And if you're on Zoom, I'll be monitoring the chat, and please type your questions in there. We'll be happy to engage you. Welcome, Dr. Ospina. Just a second, let's get the technology going here. That's it.
So, first of all, thank you so much for that introduction. I feel I slept here today because I've been here in this room since I was probably like 9 a.m. or so. I guess I'm with this one. Okay, so first of all, I have no conflicts of interest to declare, and these are my collaborators in the research I'm going to present today. The title of my talk is kind of evoking a little bit of Charles Dickens' A Tale of Two Cities, and it's about geographic inequalities of respiratory health services utilization in Edmonton and Calgary. And this is research that was funded by the Respiratory Health Strategic Clinical Network, the Women's and Children's Health Research Institute, and the Canada Researcher Program. So I just want to start showing you this picture. This is from Sao Paulo. I lived in this city in my late 8 years. And you can see on the right side is Spatial is a favela that is located right next to one of the wealthiest neighborhoods of Sao Paulo, Morumbi. So I believe this picture captures quite dramatically the gap that exists in Sao Paulo between the rich and the poor, and in a very, very extreme way, how place of residency is a very important determinant of health. So in this lecture, I'm going to explore geographic inequalities that go beyond economic inequalities as they relate to the divide between rich and poor places in the distribution of health and disease. And I'm going to present an approach to estimate geographic inequalities in the respiratory health services used in the two main urban centers in Alberta, which are Calgary and Edmonton, and maybe with the hope that these methods can be also, it's just provoking to think about what kind of work can be done here in Ontario. So, as important background, respiratory diseases are a leading cause of mortality and morbidity in early childhood, And there's a strong evidence about the role of individual and environmental factors on lung function impairment in early life. And the role of socioeconomic factors has also been acknowledged as major drivers of respiratory diseases. So there's evidence showing that children of low-income families are more likely to be exposed to a variety of respiratory damaging conditions that lead to poor healthcare across the lifespan. So this is something that starts earlier, but then the effects perpetuate over time. And these factors include overcrowding, poor housing, and malnutrition, and precarious access to primary care and prescriptions from very early life. And you can even argue is also intergenerational and even start with the mother. It's very well known that material and social deprivation have also an impact across generations. And there's evidence that children of socioeconomically deprived families are more likely to have worse respiratory health compared to the affluent children. And this is a process that we know as social causation. We were talking about causation in our ethics class. So this might also negatively impact child physical, cognitive, and psychosocial development, and the living conditions and health outcomes as adults later in life. And this is a phenomenon that we know as reverse causality. So health inequalities, we want to define these are quantitative differences in health outcomes among populations. And in Canada, they have been well established for many health outcomes, such as smoking and cardiovascular diseases and diabetes. There's a lot of gaps and inequity gaps that have been documented. And in terms of child health, I can tell you that 1 in 4 children from poor neighborhoods are vulnerable in at least 5 of the 5 core areas of development, either physical health or emotional well-being, or in language skills and communication skills. We conducted, my research group, my lab, conducted a previous study that was published in Pediatric and Perinatal Epidemiology that describe patterns of inequalities across socioeconomic groups for a variety of pediatric respiratory conditions in Alberta. And we found that material and social deprivation impacted hospitalizations and emergency care for respiratory symptoms in early childhood. So in this study and in this graph that you are seeing here, what we did, we aggregated respiratory health events by socioeconomic status groups, going from the most deprived to the less deprived, regardless of the place of residency. And even, although we found, you can see in this line here is kind of the line of equity. And what we're showing here is a gradient in terms of inequity that is affecting the most deprived groups in terms of the use of health services utilization. The problem, and these are concentration curves, and it's a method to evaluate health inequalities. And they are all significantly different from the equity line. But the problem with this graph is that we don't know, there's a disconnection in terms of the geographic dimension in the distribution of these health inequities. And this brings to the topic about the importance of geography as an important determinant of health. And the geography of health inequalities examine the role of place of residency in shaping health gaps among populations, and also linking social and environmental factors to a specific place. So these studies using this geographic approach produce relevant information for guiding health promotion strategies and targeting, and it helps the organization of health services delivery to narrow health gaps in populations that are that need it the most. So it's a very efficient method to do that. So This study was kind of filling a knowledge gap as there was no previous studies examining the geographic differences in the utilization of pediatric respiratory health services in Alberta. So the objectives of the study were to evaluate geographic inequalities in respiratory health services in early childhood in the two largest urban centers in Western Canada, in two of the largest, I'm not forgetting and quantify the magnitude of the spatial gaps in the use of respiratory health services. So I'm going to give you a little bit of a study overview, and you're going to notice that the database is probably administrative health data that we use for this study is very similar to what is used here in Ontario in terms of the ICS data repositories. So this is a cross-sectional geographic analysis of data that were obtained for a retrospective cohort study that I have. Is a cohort that I assembled of all single colon birds that were born in Calgary and Edmonton between 2005 and 2010. And the way we assembled this cohort was using all these data repositories that you see on the left side of the slide. So there is a clinical perinatal registry. I'm going to go through these data repositories in a minute. But the important concept here is that we obtain the postal codes of a maternal place of residency at delivery. So the particularity of this cohort is that it combines mother and child information, right? So we're using the maternal postal code at the moment in which they were giving birth to identify whether the children were born in Calgary or Edmonton city limits. And then we obtain individual data for the child on hospitalizations and emergency visits that happen between birth and 5 years of age that were associated with a primary diagnosis of a group of respiratory diseases such as bronchiolitis, asthma, croup, influenza, pneumonia, and other acute lower respiratory infections and upper respiratory infections. So it was a group of respiratory diseases that are relevant for this early childhood period. And then we use dissemination areas as geographic units of analysis to aggregate all the data on respiratory hospitalizations and emergency department visits. A dissemination area is the smallest standard geographic area that Stats Canada use to disseminate census data. So you know the census, they go to your home, they ask you questions, and your neighborhood belongs to a dissemination area, and that's the way the census is reporting the data for that dissemination area in a variety of characteristics that were collected through the census or through the Canadian Community Health Service. So we link this, the 6 character of the maternal postal code to the corresponding dissemination area. And there were about a little bit over 5,000 dissemination areas. And we used the census from 2006 to make this linkage. And then we also include in our analysis, and we obtain data about the area level socioeconomic status, and the proxy measure for that is the Pampalon Index, which is a measure of material and social deprivation for the DAs, for the dissemination areas. And we also obtain information about some environmental pollutants like nitrogen dioxide, and particularly matter 2.5 as pollutants. So the data sources that we use, and I mentioned in my previous slide, some of them are very similar to what we have here in Ontario. However, this Alberta Perinatal Health Program is a validated perinatal registry and that collects clinical information about the delivery, about mom and the child. And it's a unique database in Alberta because it includes unique life identifiers for both mom and baby. So that allows for DOHA research. The type of research that I do is really, really relevant because you can look at the history of the mother and you can link the information from that mother to the child and what happened longitudinally in their life later. So that's pretty cool. And then we also use the discharge abstract database, which records all hospital admissions, and NACRS, which is a database that collects information about emergency visits and urgent care encounters. And these two databases collect diagnostic information using ICD codes from the International Classification of Diseases. These are codes that every time a clinician have, and they're in a hospital admission or an emergency visit. In this context, they put the diagnosis at discharge for that. And a group of nosologists, which is people that their job is get that clinical diagnosis and put it into this international classification. So the use of that database really is not for clinical purposes per se, but it's for its administration. Is a little bit like money, and this, I'm making evaluations of, from administrative point of view. But we use that data for research purposes. And then we obtain data for NO2 and PM 2.5 from land use regression models using satellite data. I have to say, I didn't do that. There's a group of researchers in Alberta that already run these land regression models to obtain information about this NO2 and PM 2.5 for biodissemination area. So the exposure in this study were neighborhood areas of inequalities. And these were defined as a gradient in the prevalence of respiratory services according to spatial filters. And I'm going to try to go slow here. So there's something called Eigenvector spatial filters. And these are latent patterns of dissemination areas in the geographic space related to the prevalence of an outcome. So you're going to see later in your training, this is similar to principal component analysis, but is using spatial data. So briefly, these eigenvector spatial filters doing this is kind of a non-parametric method to identify the spatial patterns in the distribution of an outcome, a disease, an event in a geographic space. So that's the basic concept of this. And this method is based on the composition of a geographic connectivity matrix to obtain, I'm speaking in terms of factor analysis, but put it in a geographic context. So you have a connectivity matrix to start orthogonal numerical components, and those are what we call the eigenvectors. And each eigenvector represents an independent map pattern that captures the latent spatial correlation of the variable that we just georeferenced. So the candidate eigenvectors, what happened with these things are linearly combined into a spatial filter, and the value of the spatial filter is what we can use as an exploratory variable in a regression model as a measure of neighborhood inequality from a geographic point. So the way we define the connectivity matrix for the dissemination areas goes according to a rule in which dissemination area will include neighborhoods that share boundaries based on a single point or a segment of border limits. So the candidate eigenvectors were chosen according to whether there was a positive spatial correlation using what we use is a minimum threshold of 0.25 in the Moran index. And this Moran index is a measure, is a dimensionless. It doesn't have any dimension attached, but it's a measure of a spatial autocorrelation of the data. And with the values that go from -1 to 1. And the positive values in the Moran index indicate that similar values cluster together in a map. And the negative values of the Moran index indicate the similar values that close together, okay? And then a value of 0 suggests no spatial autocorrelation, and the values close to 1 indicate a strong spatial autocorrelation. So that's the way these eigenvectors get translated into this index, and that's what we use in our analysis. So the primary outcome of the study were smooth standardized prevalence ratios at the dissemination area level. And for this, we calculated the total number of respiratory health services per individual as the sum of all the EDVCs and hospitalizations that they had between 0 years and 5 years of age. And then the totals were aggregated at the postal code level for all children and at the dissemination area level for all children living in that dissemination area. And then we calculated a standardized prevalence ratios for each dissemination area, dividing the total number of respiratory events, health services, by the expected number of services in that dissemination area. And then we use indirect standardization because this method is more appropriate when you work with small numbers or when the rates are unstable, and this is what we were expecting here in this research. So geographic inequalities in the research were defined as spatial differences in the prevalence of respiratory health services in areas that were defined by the spatial fields. So in terms of how you interpret this, the outcome, a smooth standardized prevalence ratio of 1 indicates that the prevalence of these health services use is in a particular dissemination area is equal to the expected provincial prevalence. And when the values are greater or less than 1, it indicates that the prevalence in a particular dissemination area is higher or lower than the expected provincial prevalence rate. So we use, as I mentioned before, the material deprivation status at delivery or at birth as a proxy measure of child deprivation. And we define maternal deprivation using the Pampalone index, which is an area-based composite indicator that has both a social and a material deprivation components that are obtained from census data. And the index goes from quantiles 1 to 5, where 1 is the most deprived and 5 is the least deprived. And because environmental exposures play an important role in the prevalence of respiratory problems, particularly in childhood, we also include area level concentrations of the 2 compounds that I mentioned before as covariates. And these measures were obtained from a national land use regression model that was prepared for by Highstein. This is people that have been working on these land regression models for a while. And they incorporate satellite-based estimates, and they use kind of monitoring stations in specific geographic areas to obtain this information. In terms of the statistical analysis, the relationship between the smooth standardized prevalence ratios and the spatial filter scores were tested in multivariable linear regressions models adjusted for the covariates that were operating at a spatial level. And the idea was to evaluate whether the spatial filter captured a spatial component related to the outcome that is was independent of the covariates. So we use QGIS for the maps, and we use the standard Stata for the regression model. So this flow diagram shows a little bit, and I don't want to go deep, but it shows the steps that we took for the data analysis. And probably, you don't have to share this slide later. It might help to replicate this kind of reasoning for similar steps. So the first thing we did was to run a multivariable linear regression model to evaluate the association between the standardized prevalence ratio and the material and social deprivation in quintiles. So we did that. And then from this model doesn't have any spatial filters. After that, we verified the presence of spatial autocorrelations in the residuals based on the contiguity of the dissemination areas. And then we obtained the eigenvectors, and we selected a set of eigenvectors that were statistically related to the standardized prevalence ratio. And then this group of eigenvectors were linearly combined to form the spatial filter. And then on a separate regression model, we evaluated the association between the standardized prevalence ratios and the spatial filter values. And we adjusted by the Pampalon index, by the material and social deprivation quintiles, and by the values of the environmental exposures. And from this second model that had spatial filters, we verified that there was no spatial autocorrelation in the residuals based on the contiguity of the dissemination areas. And then we categorize the spatial filters into quintiles to define areas of low or high respiratory health services utilization. And then finally, we recalculated the smooth standardized prevalence ratios average with 95 confidence intervals by the geographic areas that were defined by the spatial filter quintiles. And that's how we evaluated the geographic inequalities. So this is the study population. We had, well, this number, and I always have problems saying numbers in English, sorry, that contributed to the data for the analysis. And this table shows the distribution of children across the maternal and the social deprivation quintiles, and the number of dissemination area for each city. There were 1,431 dissemination areas in total in Calgary, and over 1,000 in Edmonton. And we found that in Calgary, 31% of the live births happen in the most materially deprived quintiles, which are the Q4 and Q5. And 45 occurred in the corresponding groups in Edmonton. And there was a lot of heterogeneity in the distribution of live births across the material and social deprivation quintiles in Calgary and Edmonton. So we have a total of 111, that number, health services that were recorded during the study period. And 60% of these episodes of care happen in Calgary, and 40% remain in Edmonton. And then here we can see the geographic distribution on this side of the material and social deprivation quintiles in Calgary. So we can see that the most materially deprived areas, which are the greenish stones here, right, were located in the northeast of the city. And the most socially deprived areas, the blue ones, were located in the central part of the city and along kind of a north-south divide. And if we look at the Moran indices on the bottom, we see that there was a high spatial autocorrelation for both indices, according to the Moran index. And here we can see on the left figure the geographic distribution of the smooth standardized prevalence ratio. So the areas of the smooth standardized prevalence ratio that are larger than 1, which is in red, were kind of small local clusters that were scattered across the north-south divide, so they were not very well connected. And the figure on the right shows the distribution of the spatial filter quintiles. The blue and the green values indicate less services for respiratory health services. Yellow spots indicate average number of services, and orange and red indicate that there are more health services utilization in the area. So we can see from this graph that the northeast of Calgary had the lowest smooth standardized prevalence ratio, while the highest values were scattered across other city areas here. So, and we found a very weak spatial autocorrelation in the index for the smooth standardized prevalence ratios. So the regression model here without the spatial filter show that compared to the least materially deprived quintile, which was the reference group, we found that the smooth standardized prevalence ratio was higher in the quintiles 2, 3, and 5, and those in the most socially deprived Q5 after adjusting for the environmental factors. So we can see that the distribution here in the adjusted R-square, that the distribution of the material and the social environmental factors only explain 2% of the variation in the geographic distribution of the respiratory health services. And then we have here the regression model with the spatial component, which is model B. And this one incorporates a spatial filter based on 14 eigenvectors that were identified from a total of 263 possible that describe different patterns of positive spatial autocorrelations. And this model was similar to model A, except that for the quintile 4 in the social deprivation index, which was now statistically significant, and the values for the particular matter were no longer significant. And the regression coefficients indicates that when neighborhood inequality increases in 1 unit change in the quintiles, the standard prevalence ratio increased by 0.99, almost 1. So the model with the spatial filter, or the model that captured the neighborhood inequalities, we can see here that it explains 17% of the geographic variation of health services utilization, and that there might be other factors independent of social economic reason and environmental factors that might account for this variability. Meaning that at the end of the day, besides deprivation, there might be other unmeasured variables that explain the geographic variation in the distribution of these services. So when the filter is not significant, that means that the geographic distribution of the social and material deprivation indices would explain the variability in the outcome. And because the filter is significant, the significance of the material and social deprivation indices remains across the geographic areas. So these are the spatial filters quintile, this figure on the left, were significantly related to the smooth standardized prevalence ratio. And that suggests a spatial gradients in the prevalence of the health services utilization for respiratory reasons. And we can see here that there is an incremental gradient of the smooth standardized prevalence ratio across the geographic areas when we define them by the spatial filters by quintiles. So we can see here how there's that kind of those responses. And then from the figure on the bottom, there was almost a 1.5-fold increase in the predicted standardized prevalence rate average between the quintile 1 and the 5 of the spatial filters. So remember that the blue and green here are less services, yellow is average, orange is more services. So in Edmonton, the geographic distribution of both material and social deprivation quintiles, we can see those in the two figures. Now we're going to talk about Edmonton. And we can see that the most deprived areas in green are located in the north and in the southeast areas of Edmonton. I don't know if anybody knows Edmonton, but I can say, that yes, this is what you regularly see. And then for the social deprivation, we can see that there is kind of a standard across the city, and this is true in terms of inner city population in Edmonton that probably has the higher indices of social deprivation. And when we look at the geographic distribution of this standardized prevalence ratio that we show here, so remember that the areas with a ratio that is greater than 1 were mainly kind of north and central, right? And then in this figure on the right, we can see the distribution of the spatial filter quintiles. And blue and green, less services in these spot areas. Yellow is the average, and orange and red are more services. And this is very interesting because in this area, there is a refinery, and is the proximity to the oil sands. Well, not that they are right around the corner, but all the pollution comes first to this north area of the city. So the regression model for Edmonton without the spatial filter showed that compared to the quintile 1, the prevalence ratio were higher for the quintiles 2 to 5 for the material and social deprivation quintiles, and for the third and fourth for the social deprivation quintiles. And then when we see here the regression model with the spatial component that incorporated the spatial filters. So these filters were based on 8 eigenvectors that were identified from a total of 214. And in this case, all explanatory variables in the model were statistically significant. So when we look at the adjusted R squared, we can say that the distribution of the material and the social environmental factors only explain 13% of the variation in the geographic distribution of the health services used. And the inclusion of the spatial filter here did not add collinearity to the regression model. And that means that the spatial filter can be interpreted as an unmeasured spatial exploratory variable that is independent from the standardized prevalence ratio. So that means that geography matters here. So for the regression coefficients, we can say that when the neighborhood inequality increases in 1 unit change in the quintiles, the standardized prevalence ratio increased by 0.98, similar to what happened in it. And for the model with the spatial filter, we can see the R squared indicates that the spatial filter explain about 23% of the geographic variation of the health services utilization. And again, that there might be other factors that are independent of socioeconomic status and the environmental factors that might account for this variation. And when we look at the spatial filter distribution, we found that the spatial filter quintiles were significantly related to the smooth standardized prevalence ratio. And this suggests a geographic gradient in the prevalence of respiratory health services in Edmonton. There was, again, an incremental gradient of the standardized prevalence ratio across the spatial filter quintiles, and about a 1.4-fold increase, or 40% more in the predicted standardized prevalence ratio average between the spatial filter class. So in conclusion, we identified a geographic gradient in the distribution of the health services, and it indicates inequalities in these two cities. So we found that in Calgary, several small conglomerates of area scattered across the city had a high demand of respiratory health services, while in Edmonton, we could see that there was a clear regional cluster spatial distribution. So looks like geography matters a little bit more in Edmonton. So we identified this spatial component, and the statistical significance of the spatial filters have many implications. So it might indicate that there are unmeasured variables at the neighborhood level, aside from the ones that we measured, that account for respiratory health services utilization. And this might include the number of healthcare facilities, the proximity to sources of pollution, the school environments, ethnic disparities. So all are factors that can explain geographic inequalities in this study. So this research highlights the importance to understand the relationships between contextual, neighborhood, environmental factors, geography to account for health inequalities. So in terms of the strengths of this study, we use a clinical prenatal validated registry, a large population-based cohort, and the linkage of data. And the limitations are that is related to the interpretation of the spatial patterns. So this eigenvector spatial filtering approach we use is one of many techniques that can be used in spatial analysis. And the way we define the connectivity matrix will affect the spatial dependence of the results. So in our study, we made a definition that, doesn't mean that is the only way to define, this. So in conclusion, there are geographic inequalities of respiratory health services used in Calgary and Edmonton that are independent of the socioeconomic status. In Calgary, with small kind of spots scattered across the city. In Edmonton, with a very clear cluster, geographic cluster. And we published another, so this work has been already published, and we also had another paper about it, the same approach, but looking at comparisons between urban and rural Alberta, and the results are pretty interesting, but I'm not going to talk about them today. So I think I'm going to stop here, and I'm happy to take questions, and thank you for being here today.
Dr. Ospina, we're going to let you field your own questions for the audience, and I'm going to monitor the chat. Anybody from Zoom has a question.
Sure.
So, Dr. Sahar.
Thanks, Maria. That was an excellent talk. I don't think I need that. Well, thank you again. That was great. I'm curious if you looked at any severity of the diseases. So maybe areas that saw more activity, they were related to more severe disease.
Frank, can you say it again?
So I asked about the outcome, if severity of the outcome had
Severity outcomes.
Yeah, no, that's a really good point, and it's a limitation of the study, because what we did was we counted diagnosis. It doesn't mean that those are real cases of the disease. So, for example, asthma, we counted diagnosis, blah, 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 blah. But when you use administrative, and you know this, when you use administrative data and you want to define a disease, you use a case finding algorithm. So it's not just the code, it's just the code in one hospitalization or two emergency visits over the last 3 years. So that's a very accurate description of asthma and not just counting diagnosis. So, and we counted diagnosis because it was about not the number of children with asthma, but the number of encounters with those diagnoses. So based on that, we cannot measure the severity of the disease. We could, if we take, okay, we're gonna change the unit of analysis. It's not gonna be for services any longer. It's gonna be children. And then I'm going to count how many visits or how many health encounters for that children. And that probably could be a proxy indicator of severity, but not very severe.
It's just because I know in Montreal, kids who come from poor neighborhoods don't have access to family doctors or pediatricians, so they tend to end up in emergency.
Yes.
Block that.
Yes, absolutely. That's exactly what we see in practice, is that the emergency department is used as a net care. It's like the support care because people don't have access to a family doctor. So you would expect more emergency departments.
Dr. Ospina, can I don't want to mess around with your computer, but can you stop sharing and then we can see you on the monitor front? Yes, question. Perfect. If you stand here, people can see you.
Yes, sorry.
That's
I'll leave the mic. Can everyone hear me?
I cannot hear you.
The question that I have is, you're often reminded in the public health field the importance of evidence-based action, and hello. So we are often reminded in the public health field the importance of evidence-based action, and besides like research and knowledge translation and synthesis. So how do you envision using the findings of your research in public health action, and what could be a possible next steps? I'm just curious to know your thoughts.
I don't need the microphone. So this is information that is very important, as I mentioned, to resources allocation. And that's exactly what is happening right now with this data. So for example, there are some programs in Alberta that are, I probably should stop.
There you go.
So there are programs that, in the past, the programs were restricted to Calgary. And is kind of the Alberta Health Services, which is, I don't know what is the equivalent here, but the health provider. They were delivering these services in Calgary, but all this disaster was happening up in Edmonton in specific areas, and they didn't know that. So this research was shared with the Alberta Health Services to provide evidence and support that they should take care of, and offer programs for asthma control in children in the northern part of the city of Edmonton. So this type of geographic analysis are useful in terms of public health for those purposes. And what is next? Well, I moved to Ontario, so I would like to do something similar here. And my understanding is that so far this kind of analysis, at least in respiratory health of in early childhood, hasn't been done yet. So next step in research would be to replicate or try to find this, what happened here. So did I answer your question?
Okay, no questions in the chat. We have time for one more.
Thank you. My question is quite basic. I would have thought that there would have been more overlap spatially between areas of material deprivation and social deprivation. But yet looking at the maps of the city, it didn't seem that way. And maybe I'm missing something about what those two concepts mean. I wonder if maybe you could offer an explanation.
Yeah, so that's I don't know if it would be a limitation or not, but it's the way we evaluate socioeconomic status using this type of data. What has been developed is two separate measures. So the material index is based on data from the census that it implies income, so data on income, on employment, and education, I think. So at the dissemination area level. And that measure is separate from the social component, which is evaluated about for example, the number of houses in that neighborhood that have single moms. So it's other indication of social that are different from these other factors of the census. So it doesn't mean that they're exclusive one to the other. I'm pretty sure in many cases they overlap, right? And when you have material deprivation, you might have or not social deprivation. So it has advantages and disadvantages that the index is not a single one, but it has two components. I believe there is a lot of gain in separating those things because from my experience with this type of research, we tend to put all the burden into the income and material aspect. And we kind of left aside the importance of the social networks in health, like social support and having kind of a kinship system, if you want to call it that way, to support healthy behaviors and even, parents for seeking care. So if there was a way to do a single index, I'm pretty sure that we will find an overlap in some of these areas. I mean, something that I didn't do here is to put together two layers of what we can, of what is the map with the material and what is the map with the social. And then we can see, combining those two indices, how the prevalence rates behave. So, start.
I'm afraid that'll probably have to be the last word. Thank you, Dr. Ospina.
Okay.
I just want to say thanks to everyone for coming. And Nikki, do you have the slide for next week? We have a special presentation next week for an additional public health sciences seminar series. Dr. Lampros Bisdunas, who is a visiting student from England, is going to be speaking to us by Zoom on the role of sleep and circadian rhythms in bipolar disorder. So this is an additional, it's an add-on seminar that we've got next Wednesday at 12:30. So please join us for that. We want to be respectful of your time. We're going to try to end at 20 minutes after the hour, so people can get on to the next activity. Thank you very much for coming today, and thank you, Dr. Ospina, for kicking us off.